Uh, good afternoon, students. Today's lecture is prostaglandins and PAP and non-steroidal anti-inflammatory drugs that you have already covered. But so far as prostaglandin and PAP is concerned, this is very important to maintain the homeostasis, to formation of the inflammation, and due to the this pyrexia, and due to the fever and all that is maintained by these PGs. And this is a very defense mechanism so far as it is physiology, biochemistry, and pharmacology is concerned. It is very important that before going through the drugs, we have to be very much conversant with this knowledge. And this is the history of the prostaglandin is very important. This was confirmed by the von Euler in 1935, who demonstrated a substance present in the extract of the human seminal fluid, which causes contraction of the isolated intestine and uterine muscles and vasodilation. This was the Nobel Prize that was obtained by the von Euler in 1970. And the substance was named prostaglandin because of its probable origin from the prostate. Bergesten and associates showed that various PGs are closely related derivatives of the lipid-soluble prostanoic acid. And Bergesten, Samselian, and Van independently obtained PGE2, and they got the Nobel Prize in 1982. So this is a very important topic so far as homeostasis is concerned, so far as I would say inflammation is concerned, pyrexia is concerned, and then fever is concerned. This is very much important. And gastric protection is concerned, gastric ulceration is concerned, and due to the analogs of the PG inhibitors or the NSAIDs, and this is very important. Now the introduction, prostanoids and thromboxane and leukotrienes are collectively known as the eicosanoids. Most are produced from the arachidonic acid at 20 carbon polyunsaturated fatty acids 5, 8, 11, 14 eicosanoic acid is the structure of the this arachidonic acid. Now, synthesis of the prostaglandin PGs are synthesized from cell membrane for phospholipids of nearly all body tissues. There are no prostaglandin stores in the body, and these are synthesized locally in response to appropriate stimuli, external, internal, mechanical, chemical, etc. These stimuli activate the phospholipase A2 enzyme, which converts membrane phospholipids to arachidonic acid. Arachidonic acid is converted to different prostaglandins, PGG2, PGH2 via cyclooxygenase COX pathways. And then we have PGG2 and PGH2 are unstable compounds and are converted to PGE2, PGD2, and PGF2 alpha in the tissues where isomerase enzymes is present. PGI2 in the tissues where prostacyclin synthesis is present, TXA2 thromboxane in the tissues where thromboxane synthesis is present. The phospholipase A2 inhibition of glucocorticoids and COX inhibitors or NSAIDs inhibit the synthesis of the prostaglandin, thereby produce anti-inflammatory action. So anti-inflammatory action is produced by both of them, like glucocorticoids and the NSAIDs. And glucocorticoid inhibitors are phospholipase A2 inhibitors, NSAIDs inhibitors are COX inhibitors. Now, this is the pathway. And this membrane phospholipids and phospholipase A2 is activated by the chemical and mechanical stimuli, and then the arachidonic acid. There are two pathways, mainly cyclooxygenase, PGG2, PGH2, by the cyclic end peroxidase. It is, isomerases. We have PGE2, PGD2, PGF2 alpha, thromboxane synthesis, TXA2, TXB2, and prostacyclin synthesis, PGI2, 6-keto, PGF. F1 alpha. Then we have lipoxygenase 12-HPET and 12-HETE, and 5-HPET and 5-HETE it is formed an LTA4, LTB4, LTC4, LTD4, LTE4, and LTC4 and D4 are SRSA, slow reacting substances A, and up to the LTF4 we have. And now cyclooxygenase pathway arachidonic acid It comprises of this COX-1 and COX-2. Is PGG2 is also COX-1. It forms PGG2, then PGH2 by COX-1, COX-2. Then from PGG2 we have PGE2. It is through the PGE2 isomerase, and it is present in the mast cells and macrophages. And PGH2, it goes through PGI2. It is through the prostacyclin synthesis. It is endothelium. PGH2 is thromboxane synthesis. It is in platelets, and TXA2 is the constrictor, and PGI2 is a dilator. It is in the endothelium. And PGG2, PGH2 is converted from PGD2 series and is to the PGD2 isomerase. It is in the brain and mast cells. And PG2 alpha, it is in the uterus, and it is from the PGH2 series. So this is all about the pathway of this. Then there are two types of the cyclooxygenase enzymes, namely COX-1, COX-2. COX-1, most normal cells and tissues work as cytokines and inflammatory mediators and accompany inflammation-induced COX-2 production. And then COX-2 is expressed in certain areas of the kidney and brain and is induced in endothelial cells by laminar shear forces. And then we have, importantly, COX-1, but not COX-2, is expressed as the dominant constitutive S form in gastric epithelial cells and is a major source of the cytoprotective prostaglandin formation. So it is being inhibited by the NSAIDs. The inhibition of the COX-1 can lead to gastric adverse events that complicate therapy with NSAIDs, thus providing the rationale for the development of NSAIDs specific for the inhibitors of the COX-2. Now we have, the recently spliced variant of the COX-1 has been identified and termed as the COX-3 enzyme. It has a COX-like enzymatic activity and is known to be involved in pain perception and fever, but not inflammation. Paracetamol is a selective COX-3 inhibitor. Now we have the comparison of the cyclooxygenase COX-1 and COX-2 enzymes. Site of action, we have COX-1 found in the many tissues, compound important for the hemostasis. COX-2 is induced by inflammatory stimuli at the site of inflammation. Effects of the activation: COX-1 is converted to orthidonic acid to inflammatory prostaglandins, maintains renal function, provides integrity to gastric mucosa, that is cytoprotective, promotes vascular hemostasis, autocrine effect causes fever. And the COX-2, we have increased pain, inflammation, vasodilatory effect, and blocks platelet clumping is the effect of the activation. Now, effect of the blocking decreases swelling, pain, and inflammation, and decreases pain and inflammation is because COX-2. And the COX-1 effect of the blocking for a prolonged period leads to the adverse effects like damage to the renal system, acute tubular necrosis may occur, sodium retention, edema, increased blood pressure because once we use the NSAIDs along with the antihypertensives, it is like that in the COX-1. And then gastrointestinal erosion, ulcer, and bleeding, etc., decreases fever due to COX-1. And the COX-2, we have, due to this blocking, we have it prevents production, vasodilation, allowing platelet clumping, which can lead to the myocardial infarction and cerebrovascular accident on prolonged use. So this is what is the difference between the COX-1 and the COX-2. Now, products from the PGs. We have PGI2. Prostacyclin is located predominantly in vascular endothelium, mainly affects vasodilation, inhibition of platelet aggregation. TXA2 is found in platelets. Main effect is platelet aggregation and vasoconstriction. This is the difference between the PGI2, TXA2, they are antagonistic. And now PGE2 causes inhibition of the gastric acid secretion, contraction of the pregnant uterus, contraction of the GI smooth muscles. PGF2 alpha main effect is contraction of the bronchi, contraction of the myometrium. And then we have the prostaglandin receptors. We have prostaglandin receptors, and prostaglandins and related compounds are transported out of the cells that synthesize them. Most affect other cells by interacting with plasma membrane G protein coupled receptors. Depending on the cell type, the activated G protein may stimulate or inhibit formation of CMP or may activate phosphoinositidine signal pathway, leading to intracellular calcium release. These are prostacyclin D, prostacyclin E, prostacyclin I, prostacyclin T, prostacyclin F. So we have different, I would say. The contractile group, prostacyclin E, prostacyclin F, prostacyclin T, couple primarily with GQ proteins and activate phospholipase C beta to generate IP3 and DAG, that sequestration is there, calcium. These secondary messenger release calcium intracellularly, resulting in excitatory response like smooth muscle contraction, platelet aggregation, etc. The relaxant group is prostaglandin D, prostaglandin E, prostaglandin I, coupled by GS. These are stimulatory proteins activate adenyl cyclase to generate intracellular second messenger CMP. Smooth muscle relaxation, inhibition of platelet aggregation are produced through CMP dependent protein kinase A. Now, this prostaglandin D, the significance is the receptor has strong affinity for PGD2, and PGE2 can also activate it. Two subtypes were DP1, DP2. DP1 is vasodilation, inhibit platelet aggregation. DP2 is guanylate inhibitor protein and inhibits CMP. Then prostaglandin E, it has the highest affinity for the PGE2. That's called the N-prostil, is a selective agonist. It is an agonist. EP1 contracts visceral smooth muscles but is less abundant in the body. EP2 and EP4 are relaxant in nature, acts by increasing CMP in smooth muscles, while EP2 is present in few organs. EP4 has a wide distribution. EP3 decreases CMP, has anti-lipolytic action, PGE2. Then we have prostaglandin T. It is characterized by the high affinity for TXA2 and abundantly present in the platelet aggregatory, cardiovascular system, immune cells, and many other organs. PGH2 can also activate prostaglandin T. Prostaglandin I, the relaxant receptor, is defined by the highest affinity for PGI2 and PGE2. And this is the SICA-prost, is a selective agonist here. It is exposed in heart, lungs, kidney, platelet, anti-aggregatory, etc. But the highest density is in the vasculature. So you have to recognize these receptors. This is the prostaglandin receptor. We have the relaxant, we have the contractility, we have inhibition, and we have CMP receptor family. In the nutshell, there is the adenyl cyclase produced here, and it has got a different, pharmacological activity. Either the receptor is inhibitory or excitatory, depending upon that. And these are all G proteins. Now PGD2 eicosanoids, major site is mast cells. What they do inhibits platelet and leukocyte aggregation, decreases T cell proliferation and lymphocytes, migration and secretion of the interleukin-1, TNF alpha, and interleukin-2, induces vasodilation, production of the CMP. Then PGE2 is kidney and spleen and heart, increases vasodilation and production, enhancement of the effects of the bradykinin and histamine, induces of uterine contraction and of the platelet aggregation, decreases T cell proliferation and lymphocytes, migration of the secretion of interleukin-1, TNF alpha, and interleukin-2. You will go through this in the pathology also, but once you have hold of this subject, you can understand pathology, you can pharmacology, you can biochemistry, you can microbiology. Now, eicosanoids, major sites of biological activity. PGF2 alpha, it is in kidney and spleen, increased vasoconstriction, bronchoconstriction, and smooth muscle contraction. PGH2, many sites, a short-lived precursor to thromboxane A2 and B2, induces induction of the platelet aggregation and vasoconstriction. PGI2, heart, vascular endothelial, inhibition platelet and leukocyte aggregation, decreased T cell proliferation and lymphocytes, migration and secretion of the interleukin-1, TNF alpha, and interleukin-2, induces vasodilation and production of the CMP. TXA2 is platelets, I already talked to you, induces platelet aggregation and vasoconstriction, lymphocytes proliferation and bronchoconstriction. TXA2 is platelets and induces vasoconstriction. Now pharmacological actions. Cardiovascular system. PGE2 and PGF12 cause vasodilation in vascular beds. They are most potent vasodilators than acetylcholine of histamine. It is a vasodilator. PGF2 alpha constricts many larger veins, including pulmonary vein and artery. Injection of the PGE2 causes hypotension, while PGF2 alpha has a little effect. Now PGI2 is potent hypotensive, and then PGE2. TXA2 is vasoconstricting in nature. PG antiperoxidase G2 and H2 are inherently vasoconstrictor but often produce vasodilation. Also PGE2 and F2 alpha stimulate heart and enhances cardiac output. Now platelets. TXA2 produced locally by platelet is a potent inducer of aggregation and release reaction. And the antiperoxidase PGG2 and PGH2 are also pro-aggregatory. PGI2 and D2 is anti-aggregatory, but the PGI2 is more potent than PGD2. Aspirin interferes with the hemostasis. That's why we give the aspirin in order to decrease the load of the platelet. So it's the anti-platelet hemostasis by inhibiting the platelet aggregatory through TXA2 in the low dose, I would say. And the uterus, we have PGE2 and PGF2 alpha. Uniformity contract human uterus in vivo, both pregnant as well as non-pregnant. The sensitivity is higher during pregnancy. Uterus is more sensitive to PG than oxytocin. So PG increase basal tone as well as the amplitude of the uterine contractions. PGF2 alpha produces contraction while PGE2 relaxes non-pregnant but contracts pregnant human uterus. So they have got a role in uterus also. Fetal tissue produces PGs. Terminal PGF2 alpha causes inhibition and progression of labor blocked by the aspirin. Semen contains abundant amount of PGs, which coordinates the movement of the sperms in the female genital tract and facilitate fertilization. And dysmenorrhea is due to the raised PG synthesis by the endometrium. That's why we give the NSAIDs at that time. PGs induce uncoordinated uterine contractions which compress blood vessels. Uterine ischemia, pain, NSAIDs are highly effective in relieving dysmenorrhea in most women. So bronchial muscle also, PGF2 alpha, PGD2 and TXA2 are potent bronchoconstrictors while PGE2 is a powerful bronchodilator. Constrictor PGF2 alpha, PGD2, TXA2 and leukotrienes on one hand and dilator one is PGE2, PGI2 on the other hand. Asthmatics are more sensitive to the constrictor as well as dilator effect of the PGs. In allergy, human asthma, leukotrienes play a more important role. That's why these are the anti-leukotrienes we give in the asthma. Asthma may be due to an imbalance between COX inhibitors have no role in allergic asthma. So these you have to, I would say, go through. GIT, PGE2 leads to the contraction of longitudinal muscles of the gut and PGF2 alpha causes contraction circular muscle. NSAIDs afford relief in familial colonic polyposis by reducing polyp formation. PGE2 causes increased peristalsis, colic and watery diarrhea blocked by aspirin. PGE2 marked reduces acid secretion in the stomach while PGI2 enhances bicarbonate levels in the stomach. PGs appear to play a role in the growth of the colonic polyps and cancer. NSAIDs, especially aspirin, blocked it and leads to the newer incidence of the peptic ulcer. Now this is some important actions of the PG in different body systems. Like we have the CVS, PGE2, PGF2 alpha and PGI2. In the cardiovascular system, vasodilation and weak inotropic is PGE2. Vasodilatory and larger veins constrict and weak inotropic hepatic PGF2 alpha, and vasodilation marked and decrease in blood pressure we have PGI2. Like platelets, we have anti-aggregatory effect PGI2, and inflammation and immunity mediate inflammation and pain through PGE2, and moderate inflammation and pain PGI2. Now I reduces intraocular pressure PGE2, reduces intraocular pressure PGF2 alpha. Now female reproductive system, contraction of the uterus and softening of the cervix, and contraction of the uterus and softening of the cervix is PGF2 alpha as well as the PGE2. Now, a male reproductive system, we have facilitate movement of the sperms and thereby fertility to the PGE2. And now PGI2, we have facilitate movement of the sperms, also have a role in penile erection by causing vasodilation. Respiratory system, we have relaxation of bronchi through PGE2 and constriction of the bronchi through PGF2 alpha and relaxation of the bronchi through PGI2. Now, stomach, we have decreased acid secretion, increased mucus secretion through PGE2 and decreased acid secretion and increased mucus through PGI2. Now, intestine, increased peristalsis or spasmogenic through PGE2 and increased peristalsis or spasmogenic through PGF2 alpha and weak spasmogenic effect through PGI2. Now kidney vasodilation, diuretic effect and renin release through PGE2, and we have vasodilation, diuretic effect and renin release through PGI2. And endocrine, we have release of the anti-pituitary hormone, steroid, insulin, TSH like action through PGE2, and release of the gonadotropin and prolactin hormone through PGF2 alpha. And these are the things which are very important, and PG is in different body systems, how it can be controlled. And pharmacokinetics. Prostaglandins can be given by oral, intravaginal, intra-amniotic, extra-amniotic, and intravenous route, depending upon the preparation and the indications. This is very important here. And most of the prostaglandins have plasma half-life of few seconds to a few minutes. These are converted to inactive metabolites which are excreted in urine. PGI2 is catalyzed mainly in the kidney. Now you know prostaglandin analogs we have. Now PG's type we have this, and PG's analogs we have this. Preparation of the administration and what is the therapeutic use. PGE1, it is misoprostol, 200 microgram tablet, 1 to 3 tablets. It is medical abortion we use for the abortion purposes. PGE1 we have gemiprost, 1 milligram vaginal pessary, and cervical priming and mild mid-trimester abortion we give. PGE2 we give alprostil, 2.5 to 25 microgram injection, erectile dysfunction, maintenance of the patency of the ductus arteriosus. PGF2 alpha is dinoprostone, 0.5 milligram vaginal gel, vaginal tablet, extra amniotic solution, induction and facilitation of labor, mid-trimester abortion. PGF2 alpha we have dinoprost, 5 milligram per ml, intra-amniotic injection, induction and facilitation of the labor, mid-trimester abortion. PGF2 alpha we have latanoprost and bimatoprost, 0.0005% eye drops. It is glaucoma treatment. So PGI2, epoprostenol, 0.5 milligram injection for prevention of the platelet aggregation in cardiopulmonary bypass, pulmonary hypertension. So these are the therapeutic use of these PG analogs. You see medical abortion, cervical priming, erectile dysfunction, induction and the facilitation of labor, induction and the facilitation of labor, mid-trimester, glaucoma, and for prevention of platelet aggregation in cardiopulmonary bypass. Now we have therapeutic use. What are the therapeutic use? Obstetrics and gynecology, abortion. PGE2 and PGF2 alpha are used in first and second trimester abortion and ripening of cervix during abortion. Intravaginal PGE2 pessary minimizes trauma to the cervix by reducing resistance to the dilatation. A single oral dose misoprostol 400 microgram is given 2 to 3 days after mifepristone anti-progestin 600 mg for medical abortion up to 49 days of pregnancy. Intravaginal misoprostol can also be given as the side effect or less with this route. PGs are also useful in midterm abortion, missed abortion, and molar gestation. So this is for facilitation of labor, induction or augmentation purpose. PGE2 and PGF2 alpha can be used in the toxemic and renal failure patients in the place of the oxytocin, and PGs do not cause fluid retention. PGE2 may also be used in intravaginal route for this purpose. Cervical priming. Cervical ripening PGE2 is low dose administered intravenously, intravaginally, or in the cervical canal, makes the cervix soft and more compliant for induction of labor. This you have to remember. Postpartum hemorrhage, PPH we call it. PPH due to atony uterus can be treated by the intramuscular carboprost 15-methyl PGF2 alpha. Injection is ergometrine and oxytocin resistant patients we use. So gastrointestinal use. In the patients of the NSAIDs induced peptic ulcer, PGE1, misoprostol, and PGE2, enprostil are helpful in early healing of the ulcers. We give for healing of ulcers. In the patient of the glaucoma, PGF2 alpha analogs like we have the latanoprost, travoprost, and bimatoprost are used topically. These days, PG's analogs are used as the first choice drugs in wide-angle glaucoma. Now cardiovascular uses, we have PGE1, is alpoprostadil, is used to maintain patency of ductus arteriosus in neonates with congenital heart defects till surgery is undertaken. PGI2, that called the ipoprostenol, is used to prevent platelet aggregation and damage during hemodialysis of cardiopulmonary bypass. Now, erectile dysfunction or importance. 2.5 to 5 microgram of PGE1, that we call alprostadil, or urethral suppository or injection into the penis, causes erection lasting 1 to 2 hours and may be used as the alternative to sildenafil or tadalafil. If we don't have these, we can give this drug. And pulmonary hypertension, which is PGI2, that's called the ipoprostenol infusion, is also helpful in the management of the primary pulmonary hypertension. Peripheral vascular disease. In the patients of the Raynaud's syndrome, where there is the constriction of the alpha receptors and other peripheral vascular diseases, and intravenous infusion of the PGI2, PGE1 provides relief from rest pain, intermittent claudication, and promote healing of the ischemic ulcers due to the vasodilatory effect of these PGs. Now, ADR, what are the ADRs? We have vomiting, diarrhea, abdominal cramps, uterine cramps, bronchospasm, fever, ADR we have. And then non-steroidal anti-inflammatory drugs that we have already been covered. It is cyclooxygenase inhibitors. We have diclofenac, ibuprofen, ketoprofen, fluoroprofen, indomethacin, pyroxicam, naproxen. Then we have COX-2 selective nimesulide, etodalac, meloxicam, nabimetone. We have COX-2 selective inhibitors, zilcoxib, itracoxib, valdecoxib, that you have already gone through. And platelet, now we have PAP. It has an intense biological activity. Discovered in 1970, has activity in nanomolar concentration. It is important, I must say, signal molecule. PAP is acyl glycerol ether phosphoryl choline. The ether linked alkyl contained in human PAP is mostly 16 to 18 carbon long chain. Synthesis and degradation. It is membrane acyl glycerophosphocholene gives lyso PAP, and then PAP is formed under phospholipase A2 and PAP acyl transferase. The second step is rate limiting. Now, the antigen antibody, reaction and variety of the mediators stimulate PAP synthesis in a calcium dependent manner in demand. No performed PAP stores like PGs. In contrast to eicosanoids, the cells which synthesize PAP is limited, mainly WBCs, platelet, vascular, endothelium, and kidney cells. PAP degrades as PAP to lyso-PAP, then acyl glycerophosphocholene gets incorporated in the membrane under PAP acetyl hydrolase and acetyl transferase. So this is the PAP, very important. Actions, PAP has many actions on many tissues like platelets aggregation and release reaction. And release TXA2 thromboxane, if we give IV injection of PAP, results in the intravascular thrombosis. WBCs, chemotactic to neutrophil, eosinophil, and monocytes, neutrophils aggregate to stick to vascular endothelium and migrate across to site of infection, release lysosomal enzymes and leukotrienes, and generation of the superoxide radicals by the polymorphs. Chemotactic may be through release of the LTB4, induces a degranulation and eosinophils. Now, PAP continues blood vessels vasodilation by EDRF, endothelial derived relaxing factor, EDRF, and fall in blood pressure on IV injection, decreases coronary blood flow when intracoronary injection due to platelet aggregation and release of the TXA2 thromboxane. PAP increases permeability, wheel antifilaire occur at the site of the intradermal injection. Injection into renal artery PAP reduces renal blood flow and sodium excretion by vasoconstrictor effect, but is partly counteracted by the local PGs. So it has been counteracted. Mechanism of membrane-bound PAP receptors are joined with G proteins coupled receptors, GQ, IP3 DAG that I have told. Calcium inhibit adenyl cyclase with GI proteins. PAP acts intracellular endothelial cells, neutrophils, pro-aggregatory fibrin binding is unmasked. Neutrophil synthase, PAP antagonist, we have a ginkgo golide B, Chinese plant, that is treatment for the stroke, intermittent claudication, sepsis, myocardial infarction, shock, GI ulceration, asthma, and contraception, no masking. Alprazolam is the antagonist of the PAP. Now, pathophysiology role: inflammatory leukocytes, PAP, inflammation site, vasodilation, exudation, cellular infiltration, hyperalgesia. Bronchial asthma, LTC4, LTD4, PAP, bronchial constriction is produced, mucosal edema is produced, eosinophil, airways, hyperactivity, typical bronchial asthma is formed. Anaphylactic shock conditions, increased PAP levels, hemostasis and thrombosis, PAP may precipitate platelet aggregation. Fifth one is PAP, implantation of fertilized ovum, ischemic states of brain, heart, and GI ulceration is produced. Now, this is the COX inhibitors, and we have the NSAIDs, we have the non-selective COX1 inhibitors, COX2 inhibitors selection, we have selective COX preferential, COX3 inhibitors, we have antipyretic and analgesic activity. Now, PGs have two major actions. They are mediators of inflammation, stimulate sensory nerve endings, and cause pain. They also allow the movement of the other inflammatory mediators like histamine, bradykinins, the side of the inflammation, and aggravate the pain. Now, the main mechanism involved in the providing pain relief requires inhibition of the formation of PGs and other inflammatory mediators, which can be achieved by inhibiting the different enzymes involved in their synthesis. Therefore, it can be achieved by inhibition of the phospholipase A, COX enzymes, and lipoxygenase enzymes, which arrests the further pathway of the events. Now, phospholipase A is inhibited by the steroids, COX enzyme, COX1 and COX2 are inhibited by the NSAIDs, lipoxygenase enzyme is inhibited by the xylitone, ZILEUTON, COX1 and lipoxygenase both are inhibited by the licofilone. So these are the antagonists of these. Now, inflammatory disease, we have inflammation cell infiltrate. Acute respiratory disease, we have a neutrophil formation. Bronchial asthma, we have eosinophil, T cell, monocytes, basophils. And atherosclerosis, we have T cell monocytes. Glomerulonephritis, we have monocytes, T cells, neutrophils. Inflammatory bowel disease, we have monocytes, neutrophils, T cells, eosinophils.